Please, Doctor.
Thank you, Chairman and dear colleagues. Actually, I'm going to talk about the type of catheters using ART, but unfortunately, all the stuff will be overlapping. So I will give a short summary of the techniques of the embryo transfer that was talked in the previous session. As we know, embryo transfer is the final and most crucial step in IVF. About 80% of the patients undergoing IVF reach the embryo transfer stage, but only a small proportion of them achieve pregnancy. The pregnancy rate after embryo transfer is dependent upon multiple factors, including embryo quality, endometrial receptivity, and the technique of the embryo transfer itself. Recently, several surveys have shown that the embryo transfer catheter ranks as high as an important independent factor in the success of an IVF program. A survey of Australian clinicians rated the type of catheter used as the third most important variable in embryo transfer. In addition, a postal survey in the UK found that the type of catheter used was believed to be the fourth most important variable. The ideal embryo transfer catheter should avoid any trauma to the endocervix and/or endometrium as it finds its way in the uterine cavity. Multiple factors may affect the success of the uterine embryo transfer, including the experience of the physician, which is very important, the use of the ultrasound guidance, the ease of the procedure, and the presence or absence of blood and the catheters used. What is the optimal embryo technique? Easily guide the transfer catheter through the external os, endocervical canal, internal os, and lower uterine segment of the uterus. With the catheter not contaminated by bacteria, mucus, or blood, place intact embryos in the middle of the uterine cavity, as we talked previously, without touching the fundus, avoiding retained embryos in the catheter and expulsion of the embryos from the uterine cavity. And what are the questions in the technique? The transfer catheter, loading of the embryos in the catheter, cleansing of cervix, insertion of the catheter into the uterus through the angle, where to place the embryo's uterus, speed of the embryo ejection, and catheter removal, avoidance of the embryo expulsion. What about the type of the catheter? These are the type of the embryo catheters, soft versus firm catheters that are used in the previous studies. And when we look at the two meta-analyses, were Bucket and Abuside, we know that the soft catheter is more successful in using in the embryo transfer catheter, and it should be preferred compared to the firm catheters. And another approach is embryo glue. Embryo glue contains hyaluron in the medium, G2, increased concentration of hyaluron in uterus at time of implantation, closer viscosity to secretions, better miscibility, and randomized controlled trial has shown that using embryo glue have increased the success rate. But their studies are not showing the same results, so only the Denver and some related groups are showing this embryo glue is effective in the pregnancy rate. Preserve residual embryos in the transfer catheter reduce the pregnancy rate. It was discussed previously, so it is important. It has been told that in soft catheters have an increased risk of having retained embryos in the catheters, but we'll see that. What about the cleansing of the cervix? Effect of cervical mucus on D-dye expansion, wiping cervix only. The pregnancy rate is 57. Aspiration from the canal, the pregnancy rate is 23%. I'm only summarizing that. And then RC studies, there are two RC studies going on with aspiration and non-aspirated cycles. There is no difference at all when you aspirate the mucus or when you don't aspirate the mucus. What about the microbial contamination of the catheter tip? When we had the posterior endocervical swabs, the pregnancy rate was 30%. When the swabs are negative, the pregnancy rates are high as 60%. So microbial contamination is another issue that should be considered. What about vigorous irrigation of the mucus? In a single program, physicians vigorously irrigating the endocervix with 20 cc of media at high pregnancy rates than those who did not. These are not randomized trials, but some reports. What about randomized trials? Flushing and no flushing, there is no significant differences between the pregnancy rates, as you see from those three studies. What about effect of intrauterine reflex of media when you're flushing the cervix? If there's no reflex, it's 25%. If there's reflex, 60%. It's a different study. But as we can tell that the reflex of media doesn't affect the pregnancy rate. What about the catheter insertion of the ultrasound guidance? It has been discussed a lot. So as we know that ultrasound guidance has positively affects the embryo transfer rates. Bladder filling, bladder placement of embryos, those are the studies that it was discussed previously. But as a summary, when you, as a RCT, randomized control trials, that is 10 millimeter depth of ET, 15 millimeter, 20 millimeters. As you know, it's 20 millimeters, 33% with increased chance of getting pregnant. So less than 10 millimeters, 149 cases implanted. Greater than 20 millimeters, none of the cases were implanted. So we can tell that in between 1.5 to 2 centimeters as depth of installation will be successful for the pregnancy. What about the bubble about the ET? If the upwards, it is 47%. If it is downwards, 45%. There is no difference between the bubble, direction of the bubble following the embryo transfer. What about the transfer catheter withdrawal